Amanda Whitehouse. I am the Palliative Care Nurse Consultant for the community for Sutton, and I am the Palliative Care Lead for the Palliative Care Hub. And I'll go around the room on my photograph. So here, beautiful Caroline, who's got a little session afterwards, so you can explain what you do. And then we have myself here, and here are the nurses here. So we have Anna, who we would, she's banded as a band 7, so she is a senior nurse, and these two here are band 6s, so they're our junior nurses. And then this lady here, Jo, is the lead for palliative care for care homes, and she's also my deputy nurse as well. We do have admin, but she's not in that picture at the moment. And we do have an operational lead as well, who deals with things, all of the finances and all of the stuff that I can't be bothered with really, or have little interest in. My interest is to give good palliative care for the person who's at the end of life. So what do we do? The palliative care, let's start off where we are based. We're a tiny, tiny team that cover the whole of Sutton. So if your person that you know, your patient or client, has a GP that works for the Sutton Trust, then we will look after that patient. So that's our alignment, that's our responsibility. So all of the Sutton GPs will refer into us. The criteria is that the person or patient that's referred to us is in the last year of life. So that is a really tight criteria. We do flex it because obviously there is no one in this world, however amazing they are, even if you are Dr. House, can estimate when someone is in the last year of life. However, we do have nice clinical tools to enable people to kind of work out what that looks like. So we would take the diagnosis and we understand the trajectory, the prognostic trajectory of diagnosis. We would then take a picture of performance and how performance has changed in terms of decline or deterioration. We then take the patient's story as well, because that's the most important part of anybody's disease pattern. And we add that all together and we then work out when the last year of life is. We will then contact that patient once a GP or a nurse or a therapy team or social care, or even the patient themselves has referred them in. We will contact them and then we will make an initial assessment. An initial assessment is what we would call a holistic assessment. So we would look at that physical well-being of the patient, the emotional well-being, psychological, the spiritual element of that person. We treat the person as a human being rather than someone that might have a clinical problem. We will then create a care plan of continual connection with that patient, whether it's a 6 or 12 weekly phone call because they're considered stable, or it might be regular visits depending on how unwell they are. So we would balance out their need and agree a care plan with them. So that would be in forms of surveillance. And obviously, if the patient is too unwell to receive a phone call or a text, we're now offering a text service. We will talk to the person that's most useful or most important to them. That might be the carer agency, it might be a member of family, or it might be a friend. But that is our link with the patient, so they are reassured there's always someone there that's thinking of them in the background. We work collaboratively with other services, so we will have a monthly meeting with every GP surgery in Sutton. We think there's around 27 GP surgeries that sign up to regular monthly meetings. That's huge for a team of 4. But we do make every effort to sit with the GP, ask them to work out on their caseload, do they have people that are living with a life-limiting disease that might be in the last year of life. So that's how we pull our referrals. We have regular MTTs with our clinicians, so that's the therapy services, our district nurses, our urgent care services, and we're just beginning to have meetings with other services such as social care and ambulance services. And what we also do is offer support for not just the patient, so we do have eyes on the patient. We look at people clinically and manage their symptoms. We talk about their current status. We also talk about looking into the future and what that might look like in terms of becoming more unwell, when they are dying, at the point of death, and after death as well, to reflect on Claire's thoughts. And we reassure GPs and services that might just go in periodically that we are continually supporting that patient. We have lots of advice regarding any palliative care matters. So we encourage people to call into the hub with any kind of question. I've been in place now for a year this week. And previous to that, it was called the Coordination Hub, but we have changed so much. We don't just do coordination now. We actually physically do care for patients and advise GPs with prescribing. But what we do encourage is people to keep on calling in, even with, a question that might not be relevant to palliative care. We can then coordinate that problem and reassure you that we'll try and solve it somehow. We're very proud that we call ourselves a can-do service. We try and say there's, we try and do everything that we can to support patients that are living with life-limiting disease in the last year of life. We are beginning to work closer with the hospice and with social care, which I think historically UK-wide, I've come from Milton Keynes and Bedford. Social care and health have never really worked well together. But I think here in Sutton, the communication seems to be building in a way that the patient is always the focus of the problem, although sometimes money comes in the way here. But we are building really good relationships to ensure that people that are in the last 3 months of life or are rapidly declining, who might have social or privately funded care, have the ability and the opportunity to be referred for health funding for care. And that's a whole big session, another session, but happy to go through that if you've got any questions. We have a regular MDT, a multidisciplinary team meeting, although we're not led by a doctor. With my nurse consultant status, I'm able to lead an MDT and invite other services in place. So, for example, each week we'll have respiratory team, the neurology team, the heart failure team. We have invited, again, social care team. I think they're going to come and join us. Caroline joins us in our MDT team, and what we are able to do is look at people that we're worried about. So we have a good cards on the table situation where we discuss problems, the social concerns with this patient, and then we build a care plan following that. And then our nurses, our small team, know where they're going, but that's disseminated out to the GP, to the district nursing team, to social care, or whoever is the community of care around that patient. And that's getting bigger with an MDT procedure there. We also offer education. So yesterday I spent the whole day teaching district nurses, newly qualified nurses, urgent care nurses, and people from the ambulance crew, all the basics around palliative care, what it means to die at home. It was a lovely day. It was really very good, and I offer that every month. And then today, my colleague Anna is teaching district nurses, urgent care nurses, virtual ward nurses, the mechanics of a syringe driver. I don't know whether any of you have come across a syringe driver. It's a piece of equipment that is given to people that need ongoing symptom management with some really hardcore medicines. We were talking about drugs earlier, but some hardcore medicines. And that's a rolling program as well. So it's a subcutaneous infusion. Oh, yeah. So it sits, if you can pinch an inch, that's where it goes. And it is something that flexes every 24 hours. So if a patient is experiencing pain, for example, we would encourage an oral administration of pain relief. If at any point they cannot swallow or they can't absorb the medicines, we would then go to either patches or injections. And what we don't want to do is be reactive caregivers. I have pain, therefore I give you an injection. We want to be proactive caregivers with medicines. We know you have pain, you've had regular medicines. Let's use this syringe driver to ensure that you have a continual background of medicine administration. So it's interesting, it came up yesterday with nurses. Oh, so you put a syringe driver up and kill people, you hasten their death. Absolutely not. This is about good symptom management. But it does coincide with the fact that because that person can't swallow, because their organs are so tired and weary that they can't absorb medicines properly, that syringe drivers are started with end-of-life care. However, if you're vomiting, the last thing you want to do is shove tablets down yourself. So we would put a syringe driver up with antiemetic, non-sickness medicines for 72 hours and then wean that down. So yeah, a little bit of myth busting there. What I am concerned about really is when, again, this nurse said, yes, I wouldn't let my mother have one because I didn't want her to die prematurely. So, you know, it's absolutely about symptom management. And what comes with that is I would sit with the patient and the family and explain very explicitly and very clearly about the medicines and what to expect, and that death may come as a result of the body being ready for death and not for the medicines that we give. We try not to do standardise, come to a hall and listen to PowerPoints, although they're great. We grab nurses by the hand and we take them into the home, do one-to-one teaching like that. We also do kind of on-the-spot education where we'll go into team meetings and say, right, we want 10 minutes of your time, and do small packages of teaching such as mouth care. Caroline's got a lovely film that we use as just kind of an introduction to dying, and lots of different things, but we're very bespoke as well. And one of the things that I really do enjoy, apart from giving people care, hands-on care, I am a nurse, although I'm highly graded, I do go and wash bottoms and give injections. I'm very proud to say that I am that nurse. But we do debriefing after difficult deaths, and anyone who is in community of care, including yourselves, if that's appropriate, is invited to come and talk about difficult times with patients that have had deaths, not necessarily ones that were, you know, unexpected, but it might have been that there was difficult social aspects toward that young children, or unmanaged symptoms, or something that was unexpected, and we do those with our nurses as well. We've got one coming up with a lady who's horrendous wound on her foot, and we've just done one with a young lady who wasn't under our care, but we just needed to do some debriefing. And what we learn is how each other behave when we're in that circumstance, that situation, how it makes us feel and how it makes others feel. And with an open forum, it's really good to understand that I wasn't the only one feeling that I couldn't do any more, but I felt I did my best, or, you know, I made a wrong decision. And they're really good learning platforms. So here we are. We are proud to say that we always keep the patient in focus of everything that we try and do. We bring that into our MDTs, we bring that into even functioning our day. Our day is set out as we have a red nurse. She doesn't wear red, she's just a nurse that is called out to urgent calls. So if we have a call in saying Jack Jones is in pain, there's no staff from the urgent care team, we will go out and do those medicines. The hospice have lots of syringe drivers. There's little capacity in our district nurses, so we'll go out and do the syringe drivers. Someone has died, can we go out and verify that patient? Absolutely. So our red nurse, who's Anna today, will drop everything apart from her teaching. She won't drop that, that's not allowed, but we'll go and attend these patients. And then we have an amber nurse who is seeing planned visits, so those first assessments, or calls where people were a little bit worried about and we just need to keep in touch more regularly. And then we have a green nurse who does that surveillance. She has a long list of calls to make of the, hi, how are you doing? We're not eating so well, or maybe we need to come and see you. Maybe we need to refer you to the dietitian, but picking up the nuances that otherwise would go unmissed and might lead to hospital admission, or, you know, an illness that perhaps we could have managed better. And we surround ourselves around that. And then how we work is people call us into the service for either referral, for help, or total collaboration. You can see the specialist care, hospice care are over there, and the other side is over here. So we're kind of that cog that keeps things going, very, you know, low key, understated. But boy, we're like swans with, you know, what's the analogy? The beautiful swan with the legs underneath the water. We can see here that we do dovetail in with specialist services. What, from a national point of view, we understand and we recognise is that specialist services kind of care for around about 20% of the palliative care population at any one time, because it's only around 20% of the palliative care population that needs specialist services. And we tend to do the other 80%, so that's more general services. That's the things where things aren't complex, they're kind of ticking along. Our biggest cohort of patients really are the frail, the elderly, people that are living longer, have lots of comorbidities. They may have more than one disease that they're going to die from. If that patient, we recognise that perhaps pain or psychological or social bits and pieces are becoming more complex, we will refer to the hospice. Equally, the hospice will deal with their specialist bits and pieces and may well refer back to us. But the point being, we will always understand the relationship and what the patient needs. If the patient says, actually, you know, we'd prefer to stay with the hub, we've had a good service with the hub, we will ask the hospice to do some intervention and then hand back to us. So it's a good dovetailing picture there. One of our biggest jobs is looking at the advanced care plan. Here in London, we have what's called the Universal Care Plan. So it's an accessible website. If you've got interest in advanced care planning, do have a look at the Universal Care Plan, because one of our KPIs, one of our needs mass from a national point of view and from a local point of view, is that everybody has the opportunity to discuss their wishes and wants for the future. And the Universal Care Plan is an electronic program that everyone can access to clinically, excuse me. So LAS ambulance man has been called. He doesn't, you know, it might be that this person is unable to say what they wish or want because they might have a raging infection, have become very confused or bang their head. So he can then log into the Universal Care Plan and see that Amanda had a really good conversation with Jack Jones, and Jack Jones has said, I don't want to go to St Heliers Hospital again. I had an awful experience there. I recognise that I am unwell, and they told me there was nothing more that could be done. We've all heard that phrase, right? So I don't want to go to hospital. So immediately LAS Ambo will recognise that as part of his decision making or her decision making. We are now getting calls from the ambulance service saying, we just want to check that this is okay. Jack Jones has got a temperature, he's confused. I can see on his Universal Care Plan, he doesn't want to go to hospital. His wife is saying he never liked it in hospital, it just made his dementia worse. Amanda, can we just check that this is okay? So I'll either have a phone call with the ambulance person that's in the home, or if things are slightly more complex, again, I'll jump in my car, or the red nurse will jump in the car and do a good assessment at that time. They also look at funeral wishes, things that people don't want, organ donation, anything that enables that person in the last year of life or longer to plan for what they want and what they don't want, how they want it, who they want it with, and why, which is probably the most important bit for us, the evidence around why. And it's just been improved. When I started here, I thought it was just not very good at all, but it's just been improved from a learning disability point of view. They now enable us to talk about communication and ways to communicate, not just different language, but whether there's British Sign Language that's required, or signs for people that have learning disabilities. Also, my favourite things, my favourite food, things that I don't like. So it's really in depth now. So again, if you do have a chance, have a good look at it and encourage people to get them filled in. So on the back of that, this is a film that I made when I was a lead nurse in Milton Keynes, about advanced care planning. Now in Milton Keynes, we have a handheld document, arguably, you know, slightly better or different to the electronic one, because what happens is the person, a bit like when you have your birthing plan, takes it around with them and presents it to A&E, and it was just slightly more useful. But you know, we are in a modern age now and trying to save some trees. So please bear in mind that the document isn't here in London, but the principles around advanced care planning is exactly the same. And it came up on my phone that we filmed that 5 years ago today. Came up on my memories today. So it was just on the cusp of COVID. And we worked with the Open University team, who were the production and the editors, and they managed to get it out under the height of COVID. And it played in GP surgeries and at the front of the hospital, and the rise of advanced care planning for us as Palliative Care team increased. Not necessarily from patients, but from our colleagues. They were writing their care plans because, and I confess I wrote my care plan because I was the end of life lead for Milton Keynes Hospital and was at the coalface and thought, they're going to die from this disease, or I'm going to be like Batfink and not be affected at all. So myself and my partner wrote our advanced care plans. I have 2 children and they were very much included in that. They still sit in my cabinet today. And part of my request was, if I were to be intubated with no reversible condition, then to be allowed to die naturally in Milton Keynes Hospital. And at my funeral, I am a collector of shoes. Everyone that comes to my funeral would wear a pair of my shoes. It doesn't have to be on your feet or around your neck or on your hands or whatever. And that bit still stands. Anyway, yes. So that's the advanced care plan. So you can take lots of elements, lots of real life stories back into the philosophy of the universal care plan. When we complete it, we do print it out. And within the universal care plan is also the do not resuscitate order as well. So we print that out and pop that in patients' homes. So if, as sometimes happens, Wi-Fi collapses, people can see a hard copy of that there, and that, you know, is permissible for whoever the patient allows to see. So yes, that's me kind of wrapping up the session. Just some takeaway thoughts. So anyone can call in the single point of referral. That's a bank of amazing people that are based at Circle Surgery, Wide Green Lane, who answer the calls from the public to understand and refer on to district nurses, to the palliative care team, to the 2 urgent care team, continence service, anyone who's under the care of Sutton. There's a band of people that will take your call and try and triage which direction you need to go in. We sadly are only available from 8 till 6, Monday to Friday. I am working very hard to make us a 7-day service, because since my position here, I hear stories that care and crisis care doesn't happen and crisis does happen over the weekends. Friday afternoons are our most favourite times, where we roll up our sleeves and let the calls come in, because we know people panic as we're not there at the weekend. And we are here for any adult under Sutton GP care who has a life-limiting disease. If a referral comes in and we think they're not quite in the last year of life, we'll absolutely give them a call, explain about future thinking, ask what it is that they want, and we'll go and see them. But it might be that we triage and say, we'll just keep you on surveillance. You are not needing any symptom management or clinical intervention right now, but it might be that when you do need us, you've got a telephone number for us. So that is me. That's the Palliative Care Hub. What we encourage people is, if lasting power of attorney is being thought of, and for someone that might have dementia, the symptoms are becoming more prevalent, that they would come to us and we would work together on that with the lasting power of attorney. So everybody knows the story, as Kerry said. Everybody knows my story. There's no surprises and there's no crisis. And it's a flexible document as well, so people can change their mind all the time, which we see all the time. And also, it being a fabulous world, we would fill it in when we were of the same mind, and we know all of our decisions, however things change. Well, it is a wish. It can't be a demand, because I can't predict that you will die in your sleep. But however, if you come to our service and you have a disease that you are not going to get cured from, and that we have to work with you in terms of living with your disease, then we can understand what that might mean for you in terms of symptom management and predicting what that might look like. Now, none of us have got crystal balls. However, we can certainly talk to you about the what ifs and the way that you may die. One of the important questions I encourage all of my team district nurses to ask is, what's most important to you at any milestone in anyone's disease trajectory? And more often or not, I'll either get one of two answers. What's most important to you? People will say leaving my family behind and that they're okay, or not dying in pain. And so by understanding those answers, we can absolutely unpick what pain might mean to that person, what means they wish to be supported and symptom managed. It might be that that person doesn't want to take any medicines. It might be that actually their preference is to be more sleepy than awake. So it's about unpicking all of the concerns and fears and working with them. Now, what we can't do is hasten death, talking about syringe drivers, but we absolutely can listen to the fears and concerns and the clinical symptoms that people are presenting. Pain is a very interesting experience for everybody. People experience pain differently. Your pain that you experience might be different, for someone else. And dying does hurt. It can be very painful, and people are also very worried about the medicines that we use. You've just mentioned morphine. The amount of conversations I have about, I don't want to take morphine because I'm worried about being addicted to it. We kind of turn that around and say, actually, you need this medicine because of your pain. You're not going to live long enough to have a dependency on it. And that's a blunt way of saying it. I do say it a lot gentler than that. But that's the encompassing counselling around what pain means to someone. I say get it written down.
Yeah.
And talk to, if you are, obviously you and I have just met, but if one day you are living with something that is causing you pain, then talk to the right people early. And if you're not getting good results, then you find people that can give you good results. And I think that's probably 50% of the battle, is finding the right person who understands pain from a very deep point of view. And that's where we in the hospice come.
So hello everybody. As you probably saw from the earlier photograph, I am part of the Palliative Care Coordination Hub, so part of Amanda's team. To complicate things slightly, I'm actually employed by Sutton Carer Centre. So this is also my home. and the carer centre have a partnership relationship with the NHS. And so I actually do work as part of the of that team full time from Tuesday to Friday. On a Monday, I work for Uplift. A little bit about me. So I'm Caroline, mostly known as Caro, and I am a qualified psychotherapeutic counsellor, and I work remotely most of the time. So most of the work work and the connection I have with the carers that I work with, I'll explain a bit more about them in a minute, is over the telephone, which enables me to work with a lot more people than if I was seeing people face to face. So what happens in my role is, in the team, I am the person who looks after the carers who are caring for somebody who is in that point, who's part of, you know, they're a patient of the palliative care team. The referrals come to me through the nurses, and I usually respond as quickly as I can, normally within 48 hours to the person that's being referred to me. And the way that works is that I give that person a initial call, explain what my role is, and then we have a lovely conversation where we work out between us how I can help them. And what I'm looking for in that conversation is really getting an understanding of their role, their caring role in the situation that they're in. Caring for a family member or a friend at this point in their life impacts everybody around them, everybody in the family. It's often a difficult and very challenging time. So I really seek to understand things like, what's their relationship, what's the carer's relationship like with the patient? And now you sort of, in our heads, we always think that might be, you know, it's often that must be a lovely relationship, but it's amazing, but often it isn't. So often it is, but you know, there are times where it's a fraught relationship, a difficult relationship, and they found that they are now the primary carer for somebody who they struggle to get on with. So that in itself it can be challenging. A lot of the time it's somebody they love dearly. So I'm also looking at what's the amount of time that is involved in caring for them. Are they there? Is it a full time, almost 24/7? For some people it is. You know, they sleep there. They do everything to support that person on a 24/7 basis. For other people, it might be part time in the sense that they go to work, but they fit their caring in around work. It could be that they have family members that help. So they might be the primary carer, but they might have siblings who can help, or other members of the family or friends of the loved one that might be able to help with the caring. So I try to build up a picture of the carer and what's going on for them. And also looking at what other support they have. So do they have professional carers coming in to help out with the caring role as well? What involvement do they have with any other supportive agencies that might be around? So essentially my role is very much to be a sounding board, somebody that carer can speak to and speak to honestly. Often those conversations they want to have are very difficult to have with friends and family members. They don't necessarily want to tell somebody how they're finding things difficult or what's challenging them. And I am that person that is neutral. They can offload to me. And so we focus on things like how they're coping with their caring role. You know, and what I'm looking at are they coping to start with? Is this getting to the point of overload? Is it getting too much? What can we do? What can we work on together to try and help them and give them support in their caring role? We might also be looking at their own health. So as a prime example of this, this was probably a couple of years ago, I was referred from the nurses, a couple. So both of them were patients of the palliative care team. So the couple became they were each other's carers as well. So they were both caring for each other, both at this point in their life. So you can imagine that was quite challenging for them. So I was having separate conversations with each one, supporting each one through that experience. So a carer's health is important and can often get forgotten when they're caring for somebody else as well. They're so focused on what they need to do for the other person that they put their own symptoms or own issues, whatever it might be, to one side, thinking, oh, I'll deal with that, I'll deal with that when I've got the time. And of course the time never happens. So I spend some of my time is encouraging them to make sure they don't forget themselves in this. And we do a lot of work around the importance of self-care and making sure that we're looking after ourselves when we're in that caring role. It's very easy to put ourselves second when we're in that. Family dynamics comes up quite a bit. And working around, this is where I'm often working on relationships. And in this also comes communication. So this was raised earlier by the gentleman that was here earlier who said he couldn't, he wanted to talk about his funeral, didn't he, to his son, and he wasn't able to do that. There are lots of conversations that need to happen, and the carer finds it difficult to have that conversation. So we work out a plan of how that might happen, of ways that they can do that. So we work very hard on open and honest communication with the person that they are caring for, and also other family members. Usually in this instance, it's where other family members aren't perhaps being as involved as would be helpful to that family. So I often see this. So, you know, we get there's one person takes it all on and everybody else goes, well, it's fine, you know, mum's being looked after or dad's being looked after. And actually that poor daughter or son is absolutely snowed under, and everybody else is getting on with their lives. Thank you very much. So we have conversations about having some of those difficult but honest conversations with siblings maybe, or other family members, really important. So there's lots and lots of, I'm conscious of time, but there's lots of, you know, conversations can go in different ways. And sometimes those conversations I will pull in, you know, dig into my counselling skills as well. So there might be some counselling around, particularly around relationships or historical relationship challenges that they might have with the person that they're caring for. When their loved one very sadly dies, then my role changes slightly, and I then offer bereavement support if they would like that. So I can actually work with somebody for quite a long period of time, and I continue with offering them that, if that's what they want, with offering that bereavement support for at least 6 months, and sometimes for some people that might go on a little bit longer if they are very challenged by the situation. And then the outcome for me, the sort of what I like to see at the end of that, when I like to sort of see at the end of that bereavement work, is that person moving into finding their new sense of purpose. You know, what's now in life for me, actually beginning to start their life again, which can often be lost in their caring role. Often when a carer loses a person they've been caring for a period of time, sometimes a very long period of time, they lose their role, they lose their purpose when that person dies as well. And that can be it's almost like a double loss. That can leave people feeling, you know, like they're at sea without a lifebelt. So it's an interesting role, a very, I'll be honest, and I don't mean this to sound cheesy, but it's true. I find it a real privilege to do this role and to speak to these carers when they are going through this. Was probably one of the hardest times in your life, when you're caring for somebody that you care about that's in this situation. One question that comes up quite a lot when somebody is caring for somebody is around practical things, particularly as a patient is getting towards the end of life. Carers feel their need to do their caring role properly, and that often involves making sure that the person's eating and drinking, and that they're having everything that they need, and they can become understandably quite transfixed with, I've got to get that breakfast down them, or I've got to get their lunch down them. And actually the person may be refusing and not wanting that. And we have many of the nurses as well, have many of these conversations around how actually this is all part of what happens towards the end of life. So we've got a little film that we send to people to help them to understand this. And I'm going to finish on that, because I think this is actually personally think it's quite a beautiful film about what happens at the end of life. Yeah, it's a lovely video, isn't it? It is. It tackles that yeah, but it also tackles what's a really difficult subject so beautifully and so sensitively, which is, you know, essentially what we as a team try to do as well. We try to tackle what is a, you know, difficult part of people's lives as sensitively and as thoughtfully as we can, and I can say that about the whole team. So yeah.